Maverick Physical Therapy, we have a little transformational zone 1 of running mechanics for the bases. Talking about kind of our looping and non-linear trajectories. We've got the lumbopelvic hip complex model. We're going to be taking a look at the mechanics of the right hip and TZ1. We went through in a very sophisticated fashion and broke down in TZ1 of the foot and the ankle, its biomechanics, the real motion, so bone motion of the forefoot, the midfoot, and the rear foot, and how the biomechanics of the tarsal-metatarsal, the mid-tarsal, the subtalar joint, and the talar curl joint change as they pass each other on up through being in that inverted type position. So it's in that inverted like position right there of running that in the frontal plane here. Keeps us a little bit more in an adducted position. So in terms of the hip right here, we're going to be more in an adducted position in TZ1 and TZ2. So the hip in TZ1 right here, the hip joint, we're going to talk about bone motion and we're going to talk about joint motion. So we've got the ilium and we've got the head of the femur right here, acetabular fossa, lip around it is the labrum. So in terms of the hip, I'm going to just kind of angulate it, and I might over exaggerate just a little bit to kind of show us kind of what's going on right here. So in terms of TZ1A and that transition through the forefoot, the midfoot, and the rear foot, as we talked about, unloading and developing less congruency of the mid-tarsal joint, the subtalar joint, and the ankle joint will spiral off what we like to refer to as internal rotation of the tibia. So we need the tibia to internally rotate, otherwise we're not going to use that powerful posterior lateral hip joint capsule properly, and the posterior lateral, the gluteal complex up in the hip right here, the butt, also known as the butt. We don't want the dormant booty syndrome. So the ability to get the internal rotation at the tibia right here will allow us at the tibiofemoral joint, the knee, to get the motion of flexion, abduction, so gapping on the inside of the knee joint right here, that's opening on up, as well as internal rotation. So the tibia and the femur are rotating together towards the body's midline, but the tibia is and has to be rotating faster than the femur, otherwise we're going to tear up the femur. And if we don't get that motion down at the subtalar joint and the mid-tarsal joint, we run the risk of actually not getting the bottom up chain reaction, kind of collapse and deceleration of the effects of gravity, momentum, inertia, and ground reaction force, but from the bottom up, which actually could hypothetically give us no rotation when things start moving together, or the femur rotating medially faster than what the tibia is, which again, labral shredding and tearing and friction within that joint capsule, femoral acetabular impingements, our groin, our hip, related pathologies in the form of hip flexor, quad strains, our Achilles and our calf related pathologies, but we could actually start to get just overall motion wise the wrong and the improper and the opposite motion right here. So in terms of the hip joint, let's go back to our model here that's a little more flexible. We get the motion as we're in this inverted, based on the trajectory that we are and that we're using, the velocity of our body, we're in this inverted kind of down to the right position landscape wise, because of the rounding of the bases, and especially as we shorten things up and run our smaller bases, we really overload the transverse and the frontal plane. So we get the motion of flexion right here as the femur is coming up towards the body and the pelvis is rotating towards the femur. So we get flexion. We're in an adducted position. We're getting more adduction and running out of slack in the frontal plane right there. Important then that we get and have great transverse plane motion down in the rear of the midfoot. and we get internal rotation at the hip joint right here. So a back view is that so the femur is rotating towards the body's midline right here faster than what the pelvis is. It has to in order for us to consistently and efficiently use the gluteal complex to load on up. And so that we are able to make that good proper transition into TZ2 in terms of our slide and our glide. So posterior view right here, so from the back we get flexion of the femur towards us, we get anterior rotation of the pelvis. We're in an adducted position already. We're going to get further adduction as we get internal rotation. So we also have a variety of translation, sliding and gliding. So in the transverse plane, we get, so this inferior with internal rotation right here, we're going to get kind of this inferior glide. With the flexion of the hip joint itself, we're going to get further lateral translation. So the pelvis is going to slide to the right here. Again, this is a back view. And with the pelvis rotating left lateral flexion to give us the adduction or further adduction right here, we're going to get a big anterior translation of the pelvis forward. Those are the axes that we're dealing with, those three right there, which is going to be very pivotal in helping us out in TZ2 of gait with the left hip. So we'll break things down in terms of TZ2 with both feet and ankles as well. But that's going to that translation that's all brought to us by the ability to have the strength and the stability at the foot and the ankle complex in the right leg and the left leg to be able to create what we call kind of some relative control or symmetry throughout the system despite the chaos of being on an angulated surface down and away, taking up the slack already kind of in that frontal plane, which requires us to turn on the butt a little bit more in that transverse plane, as well as the sagittal plane from being facilitated so much in that frontal plane right there. So it's TZ2 hip biomechanics right there, real and relative motion, talking about the bone and the joint motion, as well as the foot and the ankle motion as well. TZ2 coming on up of the left foot and ankle as well as the left hip.